Okay, thank you, and welcome everybody to the March 2022 JSPS Pathology Grand Rounds. Can I welcome you all to this morning's talk, and can I remind you please that if you have questions to ask of our speaker, can you please put the questions in the Q&A box, and at the end of the talk we will have a question and answer session. So it gives me great pleasure to introduce you to today's speaker, Dr. Tim Kendall from Edinburgh. Tim trained in pathology in both Southampton and Edinburgh. Tim is now Senior Clinical Research Fellow in Pathology at the University of Edinburgh and a consultant liver pathologist at the Royal Infirmary of Edinburgh. His research interests include non-alcoholic fatty liver disease, mechanisms of liver fibrogenesis, and primary liver cancer. He's also the pathology lead for SteatoSite, which is a NAFLD data commons, and pathology representative to the British Association for the Study of Liver Cancer and Cholangiocarcinoma UK. In addition, he also is enthusiastic about providing histopathological support for preclinical, translational and clinical trials. He's the co-chair of the NCRI CMPath SpiritPath project to develop tools that promote the involvement of pathology and pathologists in clinical trials. And this is the subject of his lecture this morning, which is entitled Pathology for Precision Medicine Trials, SpiritPath and Beyond. Thank you very much, Tim, for agreeing to speak this morning. Over to you.
Thanks, Mark. I'll start sharing my screen now. As I was doing this, it occurred to me that it's a modern phenomenon of these sorts of meetings whereby one can inadvertently share one's desktop and email and so on. So hopefully I didn't do that then. Hopefully it's now in full screen mode and you can see what I'm going to talk about, as Mark said.
Yep, that's looking fine. Thanks, Tim.
Perfect. So I'm grateful for the invitation to talk to you and talk to PathSoc at the Grand Round about our work on clinical trials. And actually, you'll note as we go through that there's been quite a lot of support for various elements of this project from the Pathological Society right the way through it, actually. I'm also aware of the very high standard of speakers you've had at these Grand Rounds and the excellent fundamental and exciting science you had last month from Fiona Watt, and you'll have the next month from Jacob Cather and Pete Bankhead. So this sits in between those. It's slightly different, but I hope it's no less interesting or no less important. This is the outline of what I'm going to share with you. It's what we've been doing, the development process, why we did it, and then probably more interesting from my perspective anyway is the things we're going to do next and possibly how you may be able to help. I'm very aware with this particular audience of people signed up through PathSoc that I'm very much preaching to the choir in all likelihood in terms of the importance that I think, and probably you think, pathology has to clinical trials. And it's reaching the other members of the congregation who haven't come to this particular church, I suppose, is what we really need to do. I'm going to start by putting what is often the last slide, the kind of acknowledgement slide first, because all of this work has been entirely driven by its collaborative nature. And so it's very important that you understand that, really. CMPath was launched 6 years ago, and the NCRI, that's the Cellular Molecular Pathology Initiative, and it was launched to reinvigorate academic pathology in the UK, which, as many of us will know, has suffered over the last 20 years, let's say. The initiative was created in recognition of the importance of pathology in drug development and clinical research, and aims to change the way pathologists engage with and conduct, and actually more critically recognise for their work in clinical trials in the UK, and perhaps more worldwide of what we're doing now. It's now been renamed as the NCRI Pathology Group and sits as one of the cross-cutting group within the NCRI group structure, if people are familiar with that. It's funded by the agencies you see here. So we've got representation from the all 4 devolved nations, and some charities that have particularly recognised the importance of pathology to their disease-specific areas of interest. At the moment, CMPath, or NCRI Pathology Group, is chaired by Professor David Harrison, although he's imminently stepping down, and consists of multiple work streams focusing on different aspects of the work. What I'm talking about here predominantly is the Spirit Path, it's pathology and clinical trials. So the way we've organised this is with a core delivery group, and you can see the names there for yourself. But I particularly like to point out that Dr. Max Robinson from Newcastle is my co-chair on the Spirit group, and this little core team has worked well. It's fitted the Google 2 pizza rule, if anyone's familiar with that, or the US Navy SEALs unit of operation. So it's small enough that you could comfortably feed them with 2 large pizzas, not too big that it gets a bit unwieldy. It's worked really well. It's predominantly been run entirely remotely. We had 1 face-to-face meeting in the autumn pre-COVID, and everything else has been done remotely. Everyone has contributed loads, and Dr. Jane Lim at the bottom there, she was recruited by Max in Newcastle, although she's now down in London, and she led the systematic review. I'll come on to that. Not on there is Ian Lewis, who's the NCRI head of strategy and helped coordinate what we were doing until last month. We also had an advisory group that you can see listed there. We tried to get representation from all stakeholders or all sectors involved in clinical trials, so publishing, patient representatives, industry. We also wanted to try and get as broader representation from around the world as we possibly could, even though you'll see it's still predominantly North and Western Europe and North America dominated, and to be honest, Anglophone dominated. But we were pleased that we were able to get representation from Southeast Asia and from Shaheen Syed, representing a couple of organisations in Africa. And that's something we're trying to expand for the next stage of the project. And if anyone's got any particularly contacts or suggestions for people in pathologists, particularly in South America, that would be terrific. So some of you may be familiar with Spirit. It stands for Standard Protocol Items Recommendations for Interventional Trials, as you can see there. It was formed and led by Anwen Chan in Toronto. And there was a recognition that the trial protocol, which is a necessary document to guide the individuals undertaking the study, it's the basis of trial registration, review, peer review, ethical review, and funding, in fact. But there was a recognition that many of the protocols that were written, studies that were undertaken, didn't really fully address all the important elements that they perhaps should. And part of that led to inefficiency. So there was many protocol amendments that had to be made. So in 2007, a group, the Spirit Group, was formed to try and improve the completeness and quality of the trial protocols. And they developed this Spirit statement using a systematic, transparent methodology, similar to actually what we've used for our extension, with broad consultation with a similarly diverse range of stakeholders in the trials process. And they produced their original statement, the 2013 Spirit Statement, and it's been widely adopted by funders and research groups and other representative bodies since then. And it provides empirical evidence for the recommendations that they've made. As of last week, when I last looked, the 2 papers that describe Spirit, one in the BMJ and one in the Annals of Internal Medicine, have been cited between them more than 5,000 times. So 2013 Spirit Statement was very broad in its range. It was to cover all interventional clinical trials. But there was a recognition, or there has subsequently been a recognition, that it didn't specifically cover some areas in enough detail. So extensions to the Spirit Statement have been created, excuse me, to address these specific areas where it perhaps isn't covered completely. This is not an exhaustive little list there, but you can see patient-reported outcomes. The reason I put that there is because the patient-reported outcomes group who were led through Birmingham, advise us and how we undertook our own extension creation, and then the artificial intelligent interventions, Spirit AI, which is the most recent. And they also provided us with some help. Again, they were based in Birmingham. So we come to CMPath. The basic question was, why do we need it? Why did we actually start doing this? So as part of the old clinical trials working group in CMPath, we identified all the kind of rationale of that working group. Actually, was identified that cellular and molecular pathology activity in clinical trials wasn't well covered by the Spirit statement. So it was ripe for a CMPath extension to cover that. But what we want it to do, ideally, is to encourage early engagement, critically at the trial design stage, so that pathologists or other subject matter experts within laboratory medicine, laboratory scientists, are engaged with at the beginning, so that the corresponding parts of that protocol are written by the people that know what's going on. And it allows the protocol to maximize really the value of what the work is going to be undertaken. It'll also function by doing that, by engaging or triggering early engagement, we hope, raise the profile of pathology and trials generally, and make them the activities suitable for next generation pathology. So by that I mean pathology that meets the needs of precision medicine, so specific identification of molecular pathways or mutations in cancers, if we're talking about cancer trials, that stratify the groups to allow the different treatments. And in the long run, we hope it'll increase the number of trial active laboratories and pathologists, because if there's engagement with the subject matter experts, laboratory medicine and pathologists specifically, or laboratory scientists at the beginning, when the trial protocol is being written, it means that activity can be accommodated in the funding part of the application, which means funding should be available if the trial is funded to pay for the work. So rather than have someone knock on your door or knock on the door of the laboratory manager and say, oh, we've got these trial specimens we need to analyze tomorrow, and you just have to fit it in because that's just what everyone has done in the past, it should be properly funded, and so the activity should be doable sensibly. So the process that we developed the extension is broadly documented here. We started with a systematic review of what guidance there was currently available in the published literature. We then did an international Delphi survey, mapped onto the Spirit checklist, a consensus meeting, and production of written guidance. And I'll run through bits of these now, just so that people who are thinking of doing similar things, there might be some lessons you can learn. And if anyone wants to contact me afterwards about that, I'd be happy to hear from you. So the critical starting point was, what do we already know, or what is there already out there on which to start to build? And the systematic review, we were incredibly fortunate that we could have it led by Dr. Jane Lynn, who's a doctor in training, is a paediatric pathologist now down in London. But as I said, Max recruited when she was in the department in Newcastle. And she was doing a master's based out of UCL, and this was formed part of her master's project, effectively on evidence-based medicine and evidence-based research methodologies. So we did, under Jane's guidance, frankly, we were supervising, but really she was supervising upwards. Followed everything absolutely by the book in the most rigorous way you could possibly imagine. So the protocol was pre-registered on the Open Science Foundation site. And then we did a systematic review looking at everything published since 1996 that was contained guidance or a checklist, which was pathology related and relevant to clinical trials protocol, or could influence trial protocols. We didn't screen out by language of publication. And what was new to me at the time was we rated, so this is Max, Jane and I, we worked as in two pairs effectively. We rated the quality of the papers using the agreed GRS, which is a appraisal of guidelines for research and evaluation, a global rating tool. And then we also rated the confidence in the cumulative evidence, or Jane did when she was working through it with this grade CRL qual tool. Once we'd extracted the guidance, and it was only from a total of 40 papers since 96 that we could find that had anything in it. We extracted the recommendations, and then Jane synthesized them into using a best fit framework method. So we ended, actually, as you can see there from the Prisma flowchart, we started off over 10,000 records and ended up only 40 containing anything we thought met the eligibility criteria. Now, interestingly, of those 40, 4 were published by Pathological Society journals, 3 in the Journal of Pathology Clinical Research journal, and they were actually outputs of the original clinical trials working group. And then there was one other paper that was published in the Journal of Pathology slightly earlier than that. So you could argue it's true that the Pathology Society was ahead of the game in this. Once with Jane mapping it and synthesizing it, we wrote all this up. Well, Jane wrote this up, and then we published this as a standalone piece of work. And again, that was published in the Journal of Pathology Clinical Research about a year ago. And that was the basis of what we then went on to do. So using those systematic review outputs, and then a wider consultation process where we went to our advisory group members to say, have you got any local guidance that you use? And we wrote to the clinical trials unit leads to say, are there any local methodologies or guidelines that you use? So pulling the systematic review details that we retrieved from the earlier piece of work and any additional information that the advisory group or subject matter experts told us, we came up with a 48 candidate item list. So these were things that we might wish to consider documenting in a clinical trials protocol. So it's specific in as much as we are not telling people to do the thing. We will be suggesting where that thing has happened, how it should be documented. So there's a kind of implicit in that if we suggest you document a thing, the implication is perhaps we think that should be done. I'm perhaps reading between the lines a little bit and overinterpreting, but that's always the way I thought of it. So that 48 candidate list, we asked the invitees, this is individuals and organisations that we asked to participate, to rate. They were basically answering the question, do you think this item should be documented in a clinical trial protocol between 1 and 7? And we were looking for pre-specified agreement on whether it definitely should, definitely shouldn't, or there was no agreement in the middle ground. And of the invitations we sent out, 74 people participated. And they actually did cover, gratifyingly, all medical specialties involved with trials. So oncologists, pathologists, obviously, surgeons, other physicians, clinical trialists in the broadest sense, statisticians, patient groups, medical publishing, regulators, and we got a good capture from across the globe, apart from South America and Antarctica, which perhaps isn't that surprising. Gratifyingly, and I don't know whether we were surprised by this or not, to tell you the truth, of the 48 items that we offered up for potential inclusion in the trial protocol, 42 of them immediately reached consensus in. So that means the majority of items the respondents looked at and said, yep, definitely that should be there. So it did rather imply we weren't saying anything contentious, actually. Those of you familiar with Delphi processes will know that the items that don't reach a consensus in round 1, you can modify the wording of them based on feedback, because there was free text feedback available connected to each of them. And then you can go back out with a second round, which is what we did. So of the 6 items that hadn't reached consensus, we tweaked the wording, because it's amazing how much ambiguity one can accidentally include into an item that only when someone points it out, you think, oh, of course, I hadn't seen that before. So we went back out to the second round with the 6 items, and 4 of those modified items then reached consensus in, so only 2 failed to actually be included. And this is the flowchart on the right-hand side there that we ended up producing. So that's potentially the easiest part. We did that all remotely. Dan Brearley, who was a former colleague of Max's in Newcastle, but is now working in Sheffield, had done Delphi exercises before, so he'd come in to join the group as an expert on Delphi and help run that, along with some support from the NCRI, from Jack Towner, and they ran it all through online platforms. But 48 items out of rather 46 after the process is too many, and they were statements that could be merged together. So the next part, it was merging those together and then mapping them onto the spirit framework, because we needed to say at which point in that spirit guidance, in that spirit statement, did we want to expand things. And the flowchart is there. So we ended up pulling those together into 25 items, so 46 kind of condensed down to 25 composite items. And then we had a consensus meeting. Now, typically in Delphi process, that would be in person, and you would invite a wide spectrum of stakeholders to attend in person. For example, the Spirit AI, I think, had a 2-day meeting in Birmingham. They brought people in, and the budget for this originally was that's what we were going to do. We were going to have an in-person meeting, have people coming in from North America, from Australia, from Asia, get together, I'm assuming in London, and do this, but we were doing it during the times of COVID, so that wasn't possible. So we did it all online. So as a little sidebar, Lewis calculated that we saved 5,000 tons of carbon by doing it this way. So we were a green Delphi as well. So we had an online consensus meeting, which was attended by the core and the advisory group, which we added to slightly at that point, to discuss the candidate wording. So what we've done in advance is merge them, as I said, and come up with some candidate wording with a couple of rounds of email to make sure we mainly agreed. And once we then talked through all of that, we ended up with 14 items that we wanted to add it as part of the Spirit Path extension on top of the Spirit statement. So some of you can see 14 is not 25. So some of the items there, we decided after discussion, were more or less already covered, so we didn't need that. So I ended up with 14, 7 extensions and 7 elaborations, and I'll tell you what that means in just a second. And that we were finally able to publish in the Lancet Oncology in October of last year. So that's when this went live. So I'm briefly going to run through this, but I'm not going to read it all out because you can see it there for yourselves, but it's to pick out some highlights, and all this information, the methodology, but particularly from a user's perspective, this actual extension is available on the NCRI CMPath or Pathology Group website, and also obviously on the Lancet Oncology site itself. I'll be referring to elaborations, as you can see there, elaborations or extensions. So an elaboration is where the Spirit statement covered it broadly, but not quite in enough detail. So an elaboration just kind of explains it a bit more. And then an extension item was where it wasn't really covered at all in the Spirit statement. So it was a new extension that we were bolting in. And they're linked to the different categories of the Spirit statement. So many of them are administrative, and a lot of these are largely common sense, actually. So it's, as you can see there, specifying exactly who did what. So we're talking about early engagement with pathologists. They need to be named for credit and for transparency, frankly, need to be named in the trial protocol. Blame my eyes, excuse me. And then there's things that one would actually hope had always been covered, like describing the pathogenesis of the disease. It'd be difficult to write a trial protocol without really explaining the disease. There are some specific items now here that you can see extensions appearing, and this is really the full details of who, what, where, and why. And this is really the what and where. So it's asking for the trial protocol to document exactly what cellular and molecular pathology activity is going to take place and the specifics of that. So what's the laboratory? What training or standards have to be in place in that laboratory? And then there's full details really of the specimen pathway, whatever that specimen is, and exactly what assays or tests are going to be undertaken. It's stuff that I would suggest we all think is obvious, and yes, that of course that should be there. Why would it not be? But maybe you wouldn't be surprised that it's not always covered very well. There's a specific extension down there at 18A3 for the specific histochemical, molecular, or immunohistochemical techniques. I'll flag this one here. We aimed to future-proof, I guess, the CMPath extension by explicitly including digital pathology and a whole slide, or digital pathology slide archiving or analysis. Even though it hasn't been used lots yet, it certainly will do. So we asked here for any intended use of the pathology slide archive to be documented. The idea really is if you think about sequencing that's done in trials or in any published study, the raw sequencing data usually has to be deposited in a publicly accessible form. There's no reason, frankly, why raw whole slide images, as long as they're anonymized or coded, are not similarly deposited and available. I know there's cancer genome atlas have slide data sets that go with their data there, but it's certainly not a common thing to do. But if we're building up archives of whole slide images for trials, then why don't we make them available? It allows people who are reading the study once it's published to go back and look at the cases and see whether they agree with the diagnosis, frankly. But also it's a data set for future use for things that we might think of now or things that we haven't even thought of now. So why is it not available? And then connected to that is the middle one down the right-hand side. If we're making digital pathology slides available after a trial, then the consent in that trial ought to be explicit in covering that, if applicable, as it says there, and how those can be made available. I think it was important that we put that in rather than get caught out and have to extend an extension, because that doesn't seem very structurally sound, frankly. And then this is something that my work through the biorepository in Edinburgh and other trials is certainly an issue that can be addressed better, which is exactly what regulatory approvals and what permissions are in place for use of any study-specific samples after the study for future studies. And it can get quite complicated. Where are they stored? Who can use them? What's the application process to use them? What's the publication or publicity process? How do other researchers know that these are available? If a patient is consented to allow it, then the implication is they want them to be used, and therefore we should make an effort to try and allow others to use them. There's also recognition that if there are samples that are still part of the patient record effectively, even though the patients have consented for them to be used for other things, the consent process should have been mindful of the fact that if a sample is used for research, it might not then be available for subsequent use that benefits that particular patient or perhaps a family member if there's a new molecular test, let's say, that becomes available. So it's always a balance, but that should be explicitly documented. So this is the summary. Too long didn't read. CMPath sort of says everything should be quite clearly documented. Pathologists and laboratory scientists should be engaged with early. The document should state exactly who was responsible for authorship, explain all the stages of the of the cellular and molecular pathology work in the trial, all stages of the specimen pathway, covering the digital pathology aspects, with this consideration about what we use subsequent samples for. So hopefully this audience, at least you, will think that's quite common sense. And I believe it is as well. So what we come on to is, we published this in October. How is it going to be used? Who's going to use it? So I did a brief, I've got rather grandly on my notes here, called it a pilot study. I don't think it's even that, but I looked at 1 year's worth of publications, so 2019 in Nature Medicine. I just chose it as a high impact journal publishing clinical trials, increasingly in Nature Medicine, didn't used to the beginning. And I looked through them all and to decide whether they their protocols would have involved activity that was within the scope of CMPath. And of the 20 interventional trials that they published in 2019, 17 did indeed have activity that I would categorize as relevant to CMPath, or CMPath was relevant to them. 16 of those, so quite the majority, were eligibility decisions, as you might imagine. So it was a requirement to review a patient's tissue diagnosis for entry into slide XYZ. Did they have the right disease that the study was treating? Then there were fewer endpoint assessments that had pathology relevance, mainly secondary endpoints. And as you might imagine, a lot of the endpoints in cancer trials were based on imaging changes or improvements rather than pathology outcomes. So this kind of shows, admittedly in a very small snapshot, that the CMPath guidelines should have really quite wide applicability. So we know that it should apply to lots of studies, and so we have asked, what is the current state? So the kind of pre-CMPath state of play, pre-CMPath baseline. How completely is cellular molecular pathology activity currently covered in protocols? So Max Robinson and Peter Robinson, who's an undergraduate, and Peter was supported by a Pathological Society undergraduate bursary for this work, sought to specifically examine what the pre-CMPath baseline adherence, as it were, to our CMPath guidelines were. And they used Newcastle as an exemplar centre, predominantly as a starting point, because that's where they're based. But Newcastle Hospital Trust is one of the UK experimental cancer medicine centres, so it's and one of the 5 NIHR patient recruitment centres. So it should reflect best practice and a good example, good representative example of what's going on in the UK. And they identified, so they're looking for interventional clinical trials that had a publicly available full trial protocol, so not a synopsis or a summary, of full protocol that was an active trial, so recruiting or in follow-up. And they excluded abridged, summary protocols or heavily redacted protocols. And they looked for these trials within the business unit for laboratory medicine, who would have captured the activity for the billing purposes, through the research arm of their NovaPath, the CellPath department, and by asking consultant pathologists who would be involved in various different trials, so would know what activity they were doing. So it's not an unreasonable thing to ask, can we have a look at your protocol, please? Now, what they then did with their search strategies, they identified them, and then where they had the trial protocol, when they asked the trial authors if they weren't publicly available for the full protocol, is then mapped it, the activity as documented in the protocol, against the CMPath guidance, whether it was not covered as it should have been, partially covered, or covered as the CMPath guidance would have said. And Max and Peter independently checked against the checklists and then cross-referenced to one another, and they used a pilot assessment process to train and calibrate themselves about how to do this. And you can see the flow diagram there on the left. And I would state this is one of the more well, maybe not surprising, but disappointing things, is that of the trials that they found, and there were quite a lot, only very, very few actually had publicly available full protocols. Despite them going out and asking for those. So of the 210, only 25 of ongoing trials had full accessible protocols or full protocols available, and they only could actually assess 19, which is an interesting finding in itself. And this little heat map is what they found when they mapped those 19 against the CMPath guidance. So some things were covered very well. You can see there's lots of green in 18. So 18, if you can remember, is the kind of documentation of the trial's activity. But there's quite a lot of red where things weren't covered properly. And that's in certain elements here, like 5, that's the administrative parts of it. So they're actually bothering, that's pejorative, isn't it? Beg your pardon. Documenting in the trial protocol which pathologists were actually, or laboratory scientists were actually involved in writing the protocol, you know, giving those authors appropriate credit. And that wasn't done very well. And there was this is the first submission rather than the revised data. And actually there was a split. The commercially sponsored trials did that far less than the academic or charitably funded trials, actually. So what that's shown is that some things are covered well, but some things, there is a lot of scope for improvement if the CMPath guidelines are followed. And as you can see there at the bottom, this work again was submitted to the Journal of Pathology Clinical Research, and we are currently, or Max and Peter are currently revising after the first submission, and that's actually quite close to being able to go back in. So Jane had provided some comments just this morning about that. The comment I said about inaccessible, unavailable trial protocols is something that people are very aware of. And when Chan said that the lead for Spirit itself has done a lot of work about this, but the European Medicines Agency has announced, or in fact it's come into force, if it went through as planned on the 31st of January this year, a change to clinical trial conduct under the clinical trials regulations. And under this new legislation, there'll be an increased requirement for transparency about the protocol and what they've called information on the authorization, conduct and results of each clinical trial carried out in the EU to be publicly available. So that's not explicitly the full protocol, but the full protocol would cover that. And this is, if there are any trials that you're involved with, and I'm going to do this in the future, I will try and make sure that the authors, if it's funded, make the protocol available, because why are we keeping it secret? Why are we keeping it secret from the patients that we're hoping to have work with us and help us for everyone's benefit? It doesn't make any sense to me. Perhaps that's naive. So I'll finish off with an ongoing study, the kind of extension of this, which is CONSORT. So many of you will know CONSORT. It predates Spirit. It's widely known. It's reporting standards that, as you can see there from what it stands for. Interestingly, there has always been quite a lot of overlap between those involved in CONSORT and those involved in Spirit. You can see how the sort of mindset is very similar. But now the two groups have formally kind of joined forces and are aligning to work on updates to their CONSORT and Spirit guidelines in parallel with one another. We have recruited David Mower from Ottawa, who was heavily involved actually with Spirit and CONSORT to join the advisory group to represent CONSORT. And we've now effectively pivoted, I suppose, to CMPath guideline development, effectively using the same methodologies that we've just used for Spirit, because we can do more or less the same process. And with that in mind, Jane again is leading the systematic review that, in fact, I'm supposed to be screening journal titles at the moment. So we're doing that. If we follow the same sort of timeline, we're aiming to have the Delphi consensus meeting in Q4 of this year. So some of you might end up with invitations to the Delphi process for CMPath, and your opinions will be very welcome. if that's the case. And then the final study is less well, is less well advanced, because it's kind of in inception stage, which is a good clinical practice training module to be developed, specifically catering for pathologists in clinical trials. We're hoping that once we've developed this, it'll be openly available on various e-learning platforms, and I know the Royal College, the Pathology portal, are interested in helping with this, amongst others. We do feel it can add to what's available and kind of act as a way of allowing pathologists or laboratory scientists to kind of have a card-carrying proof of their intent and their interest, so that others can approach them at the trial inception, trial planning, just so that everyone, all the members of staff within the disciplines involved in this are kind of on the same page, really. This project hasn't started, and we'll probably be looking at recruiting probably trainees or doctors in training towards this in the future. And this is my last slide, and I said to Rachel at NCRI that I would share this at the end. So these projects are living, breathing and inclusive. I said we'll be advertising. I anticipate, I say we, I don't know who that would be, but the NCRI are advertising for a team to help do the clinical practice training in due course. But there are other opportunities for any of you, or those that you can tell about this, to get involved. Early Career Researcher Forum, any of your doctors in training can apply to join, and through that they can get involved in networking and mentoring training opportunities. The Pathology Network within the NCRI, you can apply to join, and then there'll be other opportunities and work that flows through that network, and the disease-specific groups, in fact, within NCRI, that you can become involved with. And then, as I mentioned at the beginning, David is stepping down as chair of what is now the NCRI Pathology Group. So the job advert for chair and deputy chair are open at the moment, with the deadline of the 25th of March, if anyone is interested in that. So I will stop there and stop sharing screen and take any questions that anyone may have.
Okay, thank you very much, Tim, for that interesting talk in this increasingly important area of pathologist involvement in clinical trials. Could I start off the question and answer session with a question for you, please? And that is, although we pathologists know the importance of the trial activity that CMPath covers, what do you think is the best route for recognition and understanding of this by the majority of trial protocol authors that are not pathologists? So really, I'm asking, how do we encourage adoption and use of CMPath?
Yeah, I mean, this to be honest, has always been the trickiest component of it, because it's always been the thing that's outside of our control. We could control how we did the Delphi, we could control what we wrote, but we couldn't control who would then read it. So there's a wave of publicity, and in fact, NCRI have used this grand round to kind of republicize the fact that this CMPath guidance exists. We've tried to use, and we will continue to do so, the advisory group that we have, because it's international, as a way for them to engage with their own networks at national level, because we can talk about NCRI, but we can't have any link to the Australian one or the Canadian, so they can do that. But from a UK level, and maybe European, through our European Society of Pathology representation, one of the more interesting ways, and perhaps the way that have most impact, is our engagement with the funders, because you can appeal to someone's good judgment or good nature and say, you should really address these things in a clinical trial protocol. But if you say your funder says you have to do it or you won't get the money, they're more likely to do it. I mean, that's a bit brutal. but I think it's probably accurate. And so we've been quite lucky through the support we've had at the NCRI. They've been the one engaging the funders, their own funders that I listed at the beginning there. Some of the disease-specific charities are seriously considering adopting this and putting it into part of their funding guidance. We're trying to get into and CR UK as well are quite engaged with this. We're trying to get the ears of the correct people at MRC and Wellcome with a similar thing in mind, but they've been more difficult to find the right people at the moment. As you might know, I have potential with the current head of the MRC to perhaps do that, but I think that will be the way of impacting, in bringing in change.
Okay, thank you. So we do have some questions in the Q&A box, which I will read out, starting with the first question from Lee Seung Hyun, who says, thanks for this great talk. Given the fast changing molecular and pathology and AI landscape, she has two questions. So the first one is, how often will CMPath be reviewed and revised? And her second question is, how can more items of promising value, e.g. stromal profiling, be added perhaps as a recommended item?
That's interesting, actually. We haven't, I don't believe, ever discussed the cycle for keeping it up to date. I mentioned there that the original Spirit statement was 2013, and they're working on the update now. So that's 9 years since it was done. So the short answer is I don't know, but now that that's been raised, I think we should address it and look for a process of how we kind of keep it up to date for the reasons that have been said. I don't know what the process of updating it would be, whether one assumes not going through the full thing again. So it'll probably be worthwhile seeing how Spirit and Consort do their updates and then adopting a similar process, but with a shorter timescale. About the question about stromal profiling and again, and there's a whole host of emerging technologies and spatial transcriptomics, and there's all sorts of possibilities using AI or not. We have to be very careful, and when Chan was part of the writing group and helped us as part of the advisory group for this process, he had to keep reining us in, because it's very tempting when we were developing candidate items that it became prescriptive. You should do this, and you said, no, you can't say that. You have to sort of be neutral and say you need to document this if you've done it. And it was a subtle distinction, but something I did struggle with. With that in mind, we had to keep things quite broad, and we actually do make reference to the fact that in this the Spirit AI extension is there, and that came out in 2020 in Nature Medicine, and the two can be read together. And I think the two together, so CMPath, so cellular, molecular and tissue related, and the AI, which was a bit more into the transparency of algorithms and that kind of thing, when viewed together, can be applied to most things rather than us being really specific and going to minutiae, which I don't think would be how anyone would want it done, actually.
Okay, thank you. So Graham Murray asks, many thanks for this excellent talk. How can it be ensured that pathologists receive appropriate recognition for their contribution to clinical trials? This is, or at least perceived, as a significant issue limiting pathologist engagement with clinical trials. Do you think the Spirit guidelines can achieve this?
I think they might. So by encouraging, I was going to say forcing, but again, this is the struggle I have. It's not forcing, encouraging the early engagement with pathologists or laboratory scientists, the appropriate subject matter experts in laboratory medicine at the protocol authorship stage. They will then ought to be listed in the trial management groups and on the authorship groups, and then that should mean that their work, or the work that's going to be undertaken that they have authored in the protocol, will be funded. And then that also should mean that the outputs of the trial when they're written up, so academic authorship should be there as well. It's when the danger is to knock on the door with someone holding some slides and saying, "Can you just look at this?" Or can you just? It's never just "Can you just?" And then you think, "Well, I'm doing it, but what are the terms of reference? Why are we doing this?" And you just can't deal with it. But if it's done from the very beginning, it should be explicit. And I would hope that all trials have an inclusive authorship policy. And they should do. I mean, the journals have criteria for authorship, not missing out authors that shouldn't be there, and not putting authors on that shouldn't be, or which I've mixed that one up. You know what I mean? So I would hope that this just kind of formalizes it slightly. I don't know whether our way of determining whether this has had an impact is to repeat the study that Max and Peter have done in 5 years' time and see whether that heat map has gone green, for example.
Yes, yeah, thank you. So Karen Owen asks, thank you, Tim, for a clear talk and so much guidance on where challenges are and what to include. Apologies if I've missed this. Is there a plan to provide, or perhaps they're already provided, exemplars? It might help implementation. That could be proformas or templates or protocols, perhaps with completed examples to show the level and type of content needed. Might ease things, or at least facilitate the planning and writing, a bit like your discussion about the publishing of the protocols.
Yes, absolutely. So the original Spirit statement did precisely this, with a very long exemplar discussion type paper. We'd consider doing the same thing ourselves, but it's quite how interesting it would be, quite text heavy. So the study that Peter and Max have done, in addition to saying where there was deficiencies and where there were where it was covered, they have extracted from those protocols the exemplar examples of green on their heat map. So the good examples, and that's included within I think it's within supplementary materials in that paper that we will hope is accepted for publication once the revision is resubmitted. Because they've split things by commercial and academic as a reviewer suggestion, and actually looks at coverage of Spirit as well. So that will contain some guidance of some good examples. The one thing we couldn't provide, and I looked at this as thinking about it separately, was the examples of how we might hope that the digital pathology is documented. So that would be documenting the scanner, the resolution, the file size, then how they're processed. No one's done it, and they're certainly not documented it. So I don't know, we may have to come up with, and perhaps for the NCRI site we might do this, a made up example, because there just isn't one there.
Okay, thank you. So Guy Betts asks, pathologists are rarely involved in trial conception and initial design. Does the NCRI Pathology Group provide advice for trial proposal guidance to researchers throughout the NCRI?
Not yet, but other kind of connected NCRI activities and CMPath activities do that. So some will be familiar with CT Rad, radiology, where they do provide feedback in an early study design. But there's a sort of equivalent, which is CT PAG, looking at trials with sort of biomarker, which does connect through to cellular molecular pathology, obviously, that has provided that service. The slight change in CMPath becoming the NCRI Pathology Group, I do think perhaps represents an opportunity to do that. Because there is this early review process that the NCRI groups do in their study specific way. So I sit on the it's changed its name as well now. It was the Applicability subgroup of the upper GI. So one of the aims of CMPath was to have a pathologist on each of these subgroups, and at the point at which those study groups are looking at early protocols, we kind of have to chip in and say, have you done this? Have you read the CMPath guidance and engaged it, and can you tick all these things off as a checklist, that might be a route, or that is a route that we can take to try and get this to happen.
Okay, thank you. So Gabriel Conan says, Tim, many thanks for a great informative talk. I'm interested to know if there is consideration to include experienced clinical pathologists into further research options. Some of us have done research in the past. Most opportunities are aimed at trainees, and whilst this is a good idea, I also see that with advancing experience in pathology, there may be opportunities to be had to involve experienced pathologists, which will obviously be established in clinical work, but still interested to participate.
Yeah, so this is an interesting point. And if one is thinking about clinical trials, whether with let's say a cellular pathology element, ideally you want any work to be done by the people who are in the best position to do that work. And that doesn't matter whether that's a pathologist that happens to have an academic contract, or is a pure NHS employed pathologist. If they are the consultants that do that work every day, so they are the experts, then they really should be the ones that the trial should seek out to do the work. And I mean, I've got as you know, got a University of Edinburgh contract, but if you might be a different subject area, and you should just, the trial should just try and involve the pathologists who do that most often and the experts in that. And that's one of the rationales for the good clinical practice training, is it isn't restricted, and it's not restricted at all for anyone with any honorary or substantive academic post. It's for any pathologist who wishes to do clinical trials, and perhaps that's a way of someone who has an NHS post, but they kind of need to have others know that they can do this and they want to do this, and maybe being able to metaphorically wave the piece of paper is a route to that. And I would argue that it will be great, and to allow it to happen, to allow NHS employed pathologists to do that work, the funding has to flow through to pay out their time, because it's not acceptable for them to do it, after hours, and hopefully this is a means to allow the funding to flow through for that.
Okay, thank you. So on a similar theme, I'm going to go to Nick West's question next, which is, thanks Tim, how do we ensure that the funding direction does not become restrictive to research? We obviously want pathology work funded rather than not. I agree this is important, but it is unrealistic to expect full funding for absolutely everything involved in trials research. We have had to push back in some recent trials where pathologists are preventing centres opening by saying that they, post CMPath, need funding for basic tasks like CRF completion or taking an additional macroscopic measurement, etc., which in my view should be funded by CRN money, and it is not realistic to add into a charity-funded trial grant application. So I think we need a balance. Do you agree?
Yeah, it's difficult because, and I know of trials where similar problems have occurred. I think it might depend on what day of the week and exactly what's happened as to that pathologist and that pathologist's workload as to quite how they've responded to extra request. I agree, it's not. So if it's activity that should be routine for reporting, that it's part of the college data set, let's say, then that's fine. It should be part of the routine job. Taking an extra block, if it's just taking an extra block, that's, once you trim, that's quite straightforward as well. And there's not an easy answer to this. One would, particularly because all departments and all pathologists are under such pressure, it's whether they feel they have individual capacity to do that. One hopes that they could, because it's quite a trivial, that's diminishing it, but you know what I mean. It should be quite an easy thing to do for someone who's skilled. I would hope well, this then becomes an issue of credit, is whether authorship, for example, once these are published, are really inclusive, because let's say there are studies where samples are taken in theatre by surgeons, which is one way that means we don't have to do it after it's fixed. Very often, and in those sorts of trials, the surgical approach to authorship is to be really inclusive, and anyone that provided tissue would become an author. Well, if the surgeons can do it, and we as a community consider it acceptable, then there's no reason why it shouldn't be done for pathologists as well. Obviously, not talking about funding, we're just looking at credit, but it's something that, I'm doing this thing and people care. If it's more activity than that, and it's actually going to take a decent amount of time, and I'm not going to define decent there because it's going to depend on individual circumstances, then there has to be a route to try and pay for that. And in Edinburgh, there are routes where there's a route where money is available for consultant job plans, for NHS consultant job plans for research activity that isn't specified. So there's sort of slack to allow some of that, as an example. It's not really an answer to the next question.
Okay. Thank you very much. Now we have a tradition that we do try to finish on time, and it's just gone 1 minute past 10, so we will stop there. I know there's a couple of questions from Lee Seung Hyun that we haven't had time to answer, so could I encourage Lee to put those questions into an email and send them direct to Tim, please, and Tim can answer by email, if that's okay.
Yep.
So it just is for me to say thank you again to Tim. That was a really interesting talk. It generated a lot of questions, a lot of discussion, and I hope that this will be an ongoing, increasing area of activity for pathologists who are interested in participating in clinical trials. So thank you very much indeed, Tim.
You're welcome.
That's all. So
goodbye.
Thank you and goodbye.